I want you to imagine a cosmetic procedure that is so incredibly quick. The actual physical intervention takes only 8 seconds.
Right, just 8 seconds.
8 seconds. I mean, it is heavily marketed to you as the ultimate lunchtime procedure. You walk into a brightly lit clinic, have it done, and supposedly you just go right back to your office or, your day without skipping a beat.
Yeah, that's the pitch.
But here is the massive catch they do not put on the brochure. Those 8 seconds of injection, well, they take place in one of the most anatomically crowded, hypersensitive, millimeter by millimeter regions of the entire human body.
Absolutely. The sheer physical density of this specific anatomical neighborhood, it really cannot be overstated. You're dealing with highly integrated networks of sensory nerves, vascular structures, and, well, absolute essential functional plumbing.
It's all just packed in there.
Exactly, all stacked directly on top of one another. I mean, there's virtually no empty space there. Every structure is heavily reliant on the structural integrity of the tissue right next to it.
And today, we are exploring the hidden anatomical risks of exactly that kind of intervention. Specifically, a procedure marketed as the G-shot or G-spot amplification.
Which is everywhere right now.
It really is. Now, if you look at the landscape of direct-to-consumer advertising out there, almost all the marketing focuses entirely on the promise of enhanced sexual pleasure.
Right.
But we are diving into our sources today to look at a very specific, purely mechanical risk. We want to see how injecting a dermal filler to create artificial volume in that highly integrated location can, inadvertently act as a barricade to your urinary tract.
Yeah. We are talking about something medical professionals call voiding dysfunction or urinary stream obstruction.
And our source materials paint a remarkably clear picture of what happens when cosmetic aesthetic goals collide with the fundamental physics of human plumbing.
They really do. We are pulling from 3 very different perspectives to get to the mechanical truth of this.
Right. So we have the official clinical guidelines from the American College of Obstetricians and Gynecologists, which, serve as the medical baseline.
And we contrast those directly with the glossy direct-to-consumer marketing materials from the various cosmetic clinics that are heavily pushing the procedure.
Yeah, those brochures. And to figure out how those two things can exist in the same universe, we are relying on a stack of highly detailed urological studies. They document exactly what happens when you introduce synthetic volume near the urethra.
It's a really fascinating contrast.
It is. So our mission for this deep dive is to cut entirely through that marketing hype. We want to use the pure mechanics of human anatomy to help you understand exactly what physically happens when you force a sudden artificial mass of filler into the microscopic space between the vaginal wall and the urethra.
Because it's purely mechanical.
Right. Okay, let's unpack this. What exactly does the G-shot procedure physically entail? Like, what is actually happening to the tissue in that exam room?
Well, the clinical mechanics of the G-shot, they're actually quite straightforward, which is why it is marketed as a quick outpatient service.
It's fast.
Super fast. The clinician uses a speculum to visualize the anterior vaginal wall. That is the front wall of the vaginal canal, basically the tissue plane that sits closest to the front of your pelvis.
Okay.
So after applying a local anesthetic to numb the surface, they take a needle and inject a substantial bolus, like a concentrated, localized mass of filler, directly into the submucosal tissue of that anterior wall.
And when we read about these fillers in the clinical literature, they're typically referring to the exact same compounds people use to, plump their lips or augment their cheeks, right?
Exactly the same. The sources primarily note the use of hyaluronic acid, which is a structural compound that naturally attracts and holds water.
Like a sponge.
Right, like a sponge.
Yeah.
Sometimes clinics utilize collagen and occasionally even autologous fat that's harvested from the patient's own body via liposuction, spun down and re-injected.
Okay, got it.
And the specific goal of depositing this mass is to physically augment the area widely believed to be the G-spot. The marketing materials we reviewed, they describe creating a very distinct, palpable bulge.
Right. They are explicitly aiming for a volume roughly the size of a quarter in width, projecting about 1/4 of an inch outward into the vaginal canal.
Yes.
Which, I mean, a quarter-sized bulge projecting a 1/4 inch out, that is a massive architectural change in a space that is normally measured in millimeters.
It's huge. And the rationale the clinics give is that this drastically increased surface area and protrusion will lead to increased friction and therefore, increased sensitivity during intercourse.
So they heavily promote this as a fast, painless, off-label use of these dermal fillers. The total time you spend in the clinic might be 10 to 15 minutes, but the injection itself is incredibly brief.
Taking just 5 to 8 seconds.
Right, just 5 to 8 seconds to forcefully deliver that quarter-sized volume into the tissue. But we need to look at the geographical map of this territory. Where exactly is this quarter-sized mound of filler going in relation to the rest of the body's systems?
Well, the anterior vaginal wall, it doesn't exist in a vacuum. It's immediately adjacent to the urethra. In
Right.
fact, the vaginal wall and the urethra, they share a structural fascial layer.
They're essentially glued together.
Right. And because the female urethra is remarkably short, typically only about 1.5 to 2 inches in total length, any structural change on that shared wall immediately impacts how that tube functions.
Because it's so short, there's no room for error.
Exactly. The urethra's sole purpose is to serve as a compressible conduit. It's just a tube that relaxes to let liquid flow freely out of the bladder and then pinches shut to hold it in.
So if I'm understanding this right, it sounds like inflating a tiny water balloon inside a very crowded, narrow hallway. If the balloon gets too big, nobody is walking down that hall. The pathway is entirely obstructed.
That is a perfect analogy.
Yeah.
That outward physical pressure has nowhere to go but directly against the adjacent structures.
Right.
You are introducing a localized, unyielding mass right next to a highly compressible tube.
Because it turns out inflating a balloon right next to the urethra isn't some brand new pioneering concept. I mean, reading through the urological studies in our stack, urologists do this on purpose, and they have been doing it for decades.
Yeah, what's fascinating here is that injecting collagen or hyaluronic acid into this exact specific anatomical neighborhood, it has been a recognized, established medical treatment since the 1940s.
Wow, the 1940s.
Yeah, urologists use it to treat a very specific functional breakdown called stress urinary incontinence, or SUI.
Right, and stress incontinence is the involuntary leaking of urine when the abdominal pressure spikes, like when you laugh, cough, or lift something heavy, and the internal valve just can't hold the liquid back.
Precisely. Specifically, urologists utilize this for a subset of SUI called type 3 intrinsic sphincter deficiency.
Okay, what does that mean mechanically?
Mechanically, the internal sphincter, that muscular valve that is supposed to pinch the urethra completely closed to maintain a watertight seal, it's weakened or physically compromised. It lacks the structural strength to close the tube.
So it's basically a broken valve.
Right, so urologists perform what are known as urethral bulking procedures.
Okay, so they are strategically bulking up the surrounding tissue to compensate for the broken valve.
Exactly. They take a bulking agent, the same hyaluronic acid or collagen, and they carefully inject it into the tissues immediately surrounding the urethra.
Creating that artificial pressure.
Yes. By adding that physical volume, they artificially push the inner walls of the urethra closer together. They are intentionally increasing the physical resistance of the urethra.
Oh, I see.
The added bulk provides the necessary compression so the tube stays tightly closed under pressure, stopping the involuntary leaks.
But wait a minute, I was looking at some of those cosmetic clinic brochures we pulled, and they are actively advertising this as a benefit.
Are they really?
Yeah, they explicitly claim that because the G-shot injection adds volume and supports the urethra, it can actually decrease mild stress urinary incontinence.
Oh, wow.
Right. So if the clinics are saying this extra volume cures mild stress incontinence, isn't that a 2-for-1 benefit? Why are we framing this increased urethral resistance as a dangerous risk for the listener?
Well, if we connect this to the bigger picture, you have to look at the baseline state of the patient's anatomy before the needle ever pierces the skin.
Okay.
Increasing urethral resistance by injecting a bulking agent is only a functional benefit if your internal valve is broken and leaking.
Ah, right.
It's a highly calculated medical intervention designed to create a physical obstruction where one should be, but naturally isn't.
The urologists are actively trying to construct a roadblock to fix a severe leak.
Exactly. But consider the baseline of a woman walking into a cosmetic clinic seeking a G-shot. The vast majority of the time, her urinary tract is completely normal and healthy.
It's working fine.
Her internal sphincter regulates the flow of urine perfectly. If you take a quarter-sized bolus of hyaluronic acid and forcefully inject it into that healthy, tightly regulated space, you are no longer fixing a leak.
What are you doing then?
You are creating excessive, entirely unnatural urethral pressure. You are artificially clamping down on a tube that was already functioning perfectly.
Here's where it gets really interesting, and honestly, a bit alarming. It is exactly like putting a kink in a garden hose.
Yeah.
A little pressure on the hose stops a leaky drip at a broken nozzle, right? But if you clamp down too hard with a giant bolus of filler on a perfectly healthy hose, the water backs up entirely and you've got a plumbing disaster on your hands.
That is exactly it. And the medical terminology for that plumbing disaster is voiding dysfunction, which frequently manifests as acute urinary retention.
So the body just can't get rid of the fluid.
Right. When that excessive pressure from the injected filler compresses the urethra, the detrusor muscle, that's the smooth muscle in the wall of the bladder that contracts to push urine out, it simply cannot overcome the artificial resistance.
Wow.
The patient entirely loses the physical ability to empty their bladder.
And the urological data in our sources, it leaves no room for ambiguity about how common this can be. We are looking at studies where highly trained specialists are injecting these exact agents, trying to carefully treat incontinence, and the complication rates are still striking.
The data on acute urinary retention following these injections is, well, it's sobering.
Yeah.
When urologists use bulking agents, acute urinary retention is universally recognized as a major, heavily documented complication.
Because we have actual numbers on this.
We do. One clinical study in our stack tracking periurethral injections, which is an anatomical injection pattern remarkably close to the G-shot, it noted a retention rate of 30%.
30%.
That means 6 out of 20 patients in that specific cohort suddenly could not urinate after the procedure. Another study cited a 10% retention rate.
Almost 1 in 3 women in that controlled group experienced a complete inability to pass urine after having filler introduced into that specific space.
And remember, that is in a strictly controlled urological setting where doctors are using specialized cameras called cystoscopes to see exactly where the filler is going.
Right, they can actually see what they're doing.
Exactly. Cosmetic clinics are performing the G-shot entirely blind.
Entirely blind. And I imagine that drastically compounds the mechanical risk.
It absolutely does. If a G-shot bolus is injected just a few millimeters too deep, or if the total volume is simply too large for that specific patient's unique anatomical spacing, you have a problem.
Or if it shifts.
Yeah, if the hydrophilic filler migrates or swells in the days following the injection, the patient can experience sudden, severe urinary retention.
We really need to talk about what acute urinary retention actually feels like, because the word retention sounds incredibly passive. It sounds like a mild inconvenience, like holding it in on a long car ride.
Oh, it is the furthest thing from passive. The kidneys are continuously producing urine, which travels down to the bladder.
They never stop.
They don't. If the exit tube is completely barricaded by the pressure of this filler, the bladder continues to fill, stretching the muscular walls further and further beyond their natural capacity.
That sounds excruciating.
It rapidly becomes incredibly painful,
Okay.
and it is universally classified as a medical emergency.
So if you get this 8-second cosmetic shot on your lunch break to, enhance your weekend, and by dinner time your bladder is painfully distended and you physically cannot urinate, what is the mechanical fix?
Well, the immediate mechanical fix requires a visit to an emergency room or an urgent urology consult to have a catheter inserted.
Oh,
Yeah, a medical professional has to physically force a rigid tube up through your narrowed urethra, pushing past the barricade created by the cosmetic filler, just to drain the backed up urine from the bladder.
and how long does that stay in?
Depending on the swelling, you might have to leave that catheter in place or learn to self-catheterize at home until the filler is actively dissolved with an enzyme injection or naturally absorbed by the body.
That completely shatters the glossy illusion of the breezy lunchtime procedure.
It really does.
But the sources highlight that simply blocking the flow isn't the only mechanical risk when you blindly introduce a needle and foreign volume into this specific tissue.
No, the sheer trauma of the blind injection carries a host of severe risks. The clinical literature frequently documents hematuria, which is visible blood in the urine,
Showing actual damage.
right, indicating direct physical trauma to the lining of the urinary tract. There is also a massively elevated risk of urinary tract infections.
Because the fluid is just sitting there.
Exactly. If the compressed bladder can't empty completely, any stagnant residual urine quickly becomes a breeding ground for bacterial growth. And in rare but catastrophic cases, the mechanical trauma can lead to fistula formation.
Wait, I saw fistulas mentioned in the complication lists. If the needle used for the G-shot accidentally goes just a fraction of an inch too deep, straight through the vaginal wall, and actually punctures the urethra itself, you are essentially punching a permanent, unintended leak into the plumbing, right?
Precisely. A fistula is an abnormal anatomical passageway connecting two organs that should remain entirely separate.
A literal hole.
A hole, yeah. If that puncture wound doesn't heal correctly, you develop a permanent hole between the urethra and the vaginal canal. This means urine will bypass the sphincter entirely and leak continuously into the vagina, requiring highly complex reconstructive surgery to close it.
Given that we are talking about a 30% risk of total urinary blockage in some clinical settings, and the potential for permanent structural damage, surely the medical establishment has weighed in on this.
They have.
What do the actual gynecological guidelines say about this procedure compared to the cosmetic marketing?
This is where we turn to ACOG, the American College of Obstetricians and Gynecologists. They are the premier professional membership organization for women's healthcare physicians in the U.S.
The ultimate authority.
Right. Their committee opinions are exhaustively researched, consensus-driven documents that dictate the standard of care. Committee opinion number 795 covers elective female genital cosmetic surgery, and it serves as a definitive, evidence-based counterweight to the cosmetic marketing.
And reading through Opinion 795, they do not mince words regarding interventions like G-spot amplification.
Not at all. ACOG explicitly warns that procedures intended purely to alter sexual appearance or function, when there is absolutely no underlying clinical dysfunction or disease, they are not medically indicated.
Period.
Right. They state unequivocally that these specific procedures lack high-quality, peer-reviewed data supporting their safety or their effectiveness.
They don't just wave away the procedure, though. They actually break down the mechanical risks, highlighting the exact complications we've been discussing.
They do. ACOG specifically warns about the high potential for urinary retention and the subsequent need for reoperation. They also highlight dyspareunia, which is painful intercourse.
Which is ironic, considering the goal of the procedure.
Exactly. And mechanically, this makes perfect sense. You are forcefully injecting a concentrated, rigid mass of hyaluronic acid into a highly innervated, sensitive space.
So it's not a soft cushion.
No. If that bolus hardens or if it constantly presses against the wrong nerve cluster, it doesn't enhance sensitivity at all. Instead, it acts as a rigid foreign body that turns normal sexual friction into severe restrictive pain.
ACOG also points out a systemic problem in our sources: the complete lack of standardized nomenclature and long-term follow-up in the cosmetic gynecology field.
So it's a huge issue.
Meaning, because this operates in the Wild West of cosmetic marketing, nobody is rigorously tracking or publishing the data on how many women end up in the ER with a blocked urethra 3 days after getting a G-shot.
Right. The clinical evidence currently relies heavily on isolated case reports of complications, rather than large, controlled, long-term studies.
Which is convenient for the marketing.
Very. And this ties directly into a fascinating dynamic raised in the medical literature regarding how the cosmetic industry actually functions.
Pathologizing the normal.
Exactly. The clinical sources point out how marketing essentially creates demand by redefining anatomical baselines, taking perfectly normal anatomical variations and framing them as conditions that require fixing.
This part of the data was incredibly revealing, the mechanics of how the industry defines what is normal.
These sources utilize a perfect example regarding a different cosmetic procedure, labiaplasty, to highlight this broader marketing mechanism. Cosmetic marketing frequently portrays inner labia that measure longer than 30 to 40 millimeters as hypertrophic, implying they are abnormally large and require surgical reduction.
Right.
But when researchers conducted a rigorous clinical study of over 600 females, the data showed that the mean length of the labia minora actually exceeded that cosmetic measurement in more than half the individuals.
Wow, more than half.
Yeah, normal, healthy measurements ranged anywhere from 7 millimeters to over 50 millimeters.
So the marketing literally draws an arbitrary line in the sand, points to the perfectly healthy majority, and tells them their natural baseline is a flaw that requires a paid physical intervention.
That's the business model.
But wait, I can hear someone looking at these clinic brochures and thinking, they heavily advertise that these hyaluronic acid fillers are temporary. They naturally dissolve and are absorbed by the body over 3 to 6 months.
They do say that.
Doesn't that mean any urinary obstruction, any voiding dysfunction is just a temporary inconvenience rather than a permanent disaster? I mean, the filler eventually goes away, so the plumbing just goes back to normal, right?
It is incredibly dangerous from a medical perspective to dismiss acute urinary retention as a temporary inconvenience.
Because of the damage it does in the meantime.
Yes. As we discussed, the complete inability to urinate is an acute medical emergency requiring immediate physical intervention. But beyond the trauma of the catheterization itself, the secondary downstream effects of that temporary blockage, they can be severe and permanent.
Because the surrounding tissue and organs, they don't just hit a pause button while they patiently wait for the filler to dissolve over 4 months.
Not at all. Even a temporary obstruction significantly raises the risk of deep-seated urinary tract infections, which can easily track upward and infect the kidneys.
Whoa, right.
Furthermore, the sheer, unrelenting mechanical pressure of an overdistended bladder attempting to force urine past a barricade, it can cause lasting trauma to the detrusor muscle.
So the bladder itself gets damaged.
Right. This can potentially lead to long-term bladder dysfunction, where the muscle loses its elasticity and strength long after the artificial obstruction is gone.
That's terrifying.
And if the delicate mucosal lining of the urethra is damaged by the constant pressure of the filler or the needle itself, the body heals that damage with scar tissue.
Which creates a whole new problem.
It creates urethral strictures, which permanently narrow the tube and require actual surgery to physically dilate.
So a temporary physical obstruction can easily trigger a rapid cascade of permanent functional breakdowns in the tissue.
Exactly. The temporal nature of the filler does not negate the permanent structural damage caused by the pressure it exerts while it is there.
So what does this all mean for you, the listener? Why should you care about the intricate mechanical details of urethral pressure, detrusor muscles, and ACOG guidelines?
It's about knowing your baseline.
Because deeply understanding the pure mechanical plumbing of your own body empowers you to cut cleanly through glossy, sophisticated marketing. It is incredibly easy to be seduced by a brochure promising enhanced intimacy and a quick fix.
Very easy.
A simple 8-second injection sounds incredibly appealing until you realize that in the highly confined, deeply integrated spaces of human anatomy, there are no isolated events.
Everything is connected.
Every single action,
We have spent this time focusing on the mechanical blockade of fluids, the risk of urinary retention. But some of the cosmetic clinic materials inadvertently mention another potential complication of the G-shot.
What's that?
They casually list side effects, like a constant, nagging awareness of the area, a feeling of persistent, unwanted sexual arousal, or a constant, unyielding sensation of needing to urinate, even when the bladder is completely empty.
Because that rigid mass of filler isn't just pressing against the urethra, it is constantly compressing the highly integrated sensory nerves we talked about at the very beginning.
Right. The mechanical pressure does more than block the physical plumbing. It triggers the neurological wiring. It sends a relentless, endless loop of sensory signals up the spinal cord to the brain.
Just constant noise.
And this raises an important question. If a cosmetic injection designed for brief moments of pleasure can inadvertently rewrite your daily neurological signals, if the pressure of that filler can literally hijack your brain's basic bathroom and arousal cues to the point of constant, maddening distraction, at what point does artificially enhancing your body actually cross the line into completely losing control over it?
That's a heavy, fascinating thought, because suddenly, that breezy 8-second lunchtime procedure in that tiny, incredibly crowded anatomical neighborhood, it doesn't just change your physical layout. It has the raw mechanical power to completely rewrite the reality your brain experiences every single minute of the day.